Hello and welcome to Let's Talk, a series of podcasts produced by the Hazel and Betty Ford Foundation on substance use issues that matter to us and issues that matter to you, including research, prevention, treatment, addiction, and recovery from substance use disorders. I'm your host, William Moyers. Thank you for joining us today. Our topic for today's podcast is quality standards in addiction treatment. And there is nobody better positioned to talk about this than my colleague, our expert, Dr. Joseph Lee. Welcome, Dr. Lee.
Thanks. Great to be here.
You are the medical director of our youth continuum at the Hazel and Betty Ford Foundation, specifically officing out of our facility in Plymouth, Minnesota. But you're also an expert on quality standards. And I think the first question we want to really get to is, what is quality in addiction treatment?
Yeah, this is an area that we're lagging behind in compared to other fields of medicine. If you look at cardiology, cancer treatment, they have standards for what good treatment is, what the evidence base is, but also how people are actually implementing that, and whether hospitals are actually doing what they say or what the research papers say. And I think in addiction, that's lagged behind. And there's many reasons for that. But over the past decades, there have been many iterations of trying to get quality standards, usually by academics. You know, and I was groomed to be an academic, and I don't function as an academic, but a lot of academics would get together and say, you know, we need to have these standards or those standards. Problem with the past iterations is that they didn't get payers to the table. It didn't have the same kind of motion and energy. But I think people are trying enough times and talking about it that it's important. It's important from a customer standpoint. They need to know what kind of treatment they're getting. It's important from a payer standpoint. They need to know what they're paying for. And it's important from a professional standpoint because we need to have an integrity about what we're doing. And I think people have seen the news a lot about people who overpromise treatment or say things that are incorrect or say that they do X, Y, or Z but don't really do it. So for all those reasons, quality assurance, quality standards, very critical in our field.
But why now? As you alluded to, we've wrangled with this issue probably since treatment was begun. We were marking our 70th anniversary as an addiction treatment provider. Why is it taking to now to get to this issue?
Well, I'm speculating a bit, but I think we live in a culture where people have information at the tip of their fingertips, and they have more information than they know what to do with. And that's good, but it's also bad, in that information can be misrepresented, and we've seen that in politics and everywhere else. And it happens in healthcare, where people can promise that you're going to get X, Y, and Z treatment, but you're not. And so I think there's a cultural shift where people have access to information, but not necessarily wisdom, and they need a way to be able to calibrate the data that they're seeing to make sure that they're getting good treatment. And then I think the opioid crisis has brought the chickens home to roost, so to speak. It's really held treatment centers accountable. You know, we use buprenorphine and other medications for opioid use disorder. There are a lot of centers that still don't. And I think there's got to be a transparency, and it can't be a philosophical issue. It's just got to be a science-based issue. And so I think there's been an outpouring of support and energy behind trying to get some quality standards.
So quality isn't about the thread count on the sheets or the tastiness of the food or the appearance of the grounds. Quality is equal to the delivery of care, right? And the outcomes of that delivery of care.
That's right. If I'm a parent in rural Arkansas or Kentucky or West Virginia or Oregon, and I have a loved one who is addicted to substances, where do I send them for treatment, and how do I know that this place will deliver, you know, the basics of evidence-based care? You know, I have this anecdote where my air conditioner broke over the summer. It was a real bummer. And I have certain expectations as a customer because I want a new air conditioning unit, and they're very expensive, but I don't know anything about air conditioners. And so the experts who, you know, install the air conditioners have to tell me kind of what they have, what the options are, and then my expectations get sharper, and then they're able to meet my capacity and my expectations. And we don't do that in substance use treatment. People are trying to get help, but they don't know what they're looking for. They're kind of blindsided, they're in a desperate state, and so they come to treatment centers and clinics and methadone clinics asking for a kind of help, and they don't even know what they're really expecting, and we don't do a good job of explaining our capacity.
But isn't it ultimately, though, they want success? But what is success, particularly in this day and age where there are so many pathways to recovery?
That's right, and until they get the menu choice of options and the pros and cons of each treatment option, I'm not sure they can really fine-tune their expectations. I'm not sure it's reasonable to expect that people can fine-tune their expectations. Once they've been to a couple of treatment clinics, seen a couple of therapists, they get a better idea of what they really want for themselves.
Now, you see patients all the time. You see family members all the time, every day of the week that you're not out speaking somewhere in the country or internationally. Most people want their loved one to get well. But what does it mean in the context of a chronic illness, substance use disorder? What does it mean to get well?
That's right. And people want different things. Some people, they want to go to a methadone clinic and they don't want to get hepatitis and they don't want to overdose and they don't want to get HIV, and that's their end goal. Family members might want grandfather to stop drinking altogether. Grandfather might want to have a glass of wine every 2 months. So when they are at the outset of treatment, they all have very different expectations of what they're wanting, but they don't know how to vet those expectations through quality assurances that they're going to actually get the treatment that they're looking for. And I think all of us have to do a better job of it, because customers are the ones that suffer. Families are the ones that suffer not knowing how to navigate this maze of various treatments. And it's hard for them because they also have to get insurance companies to play ball. And insurance companies can be squeamish if they don't know what they're paying for. And so then their criteria can be rather arbitrary, which then affects payment and access. And then you've seen online, we've called for standardization of treatment for a long time. A lot of people, you go on their website, it looks nice. They say they do XBT treatment and XYZ therapy. Who knows if that's really even happening? And so there are so many stakeholders that deserve and should be responsible for some kind of standards. I will tell you that one thing we can be proud of at Hazel and Betty Ford is we're ahead of the game in this.
How so?
Well, one of the things we realized in this quality standardization is that you can build a better mousetrap, and there's tons of data out there, but you got to ask important questions like who pays for the data? And then just because one company has the data, why would they share it with somebody else? And you're seeing the same problem happen in electronic health records in medicine. They thought electronic health records would transform everything.
Right.
But why does one hospital system want to share records with another hospital system? And then who's going to pay for the research to keep these metrics? Well, what we've done is we've created this real great live data stream where patients have a patient portal. They have evidence-based questionnaires they do weekly, bi-weekly, and they track their own progress, and which allows us to individualize care. We've done outcome studies on our treatment for a long time. So this actually makes me feel really good in terms of what we're doing, because we've been ahead of it. Before there was any cry for standardization, we've already looked at our own data, we've done our own research, we already have a system of metrics built into our electronic health records to show people this is what you're getting, this is what we're responding to. Because people need more than how many days here, how many days there. What they need to know is this is the problem I'm having. Here are some rough expectations. Can you meet those expectations?
Can success be defined even if the patient or the client isn't able to maintain continuous abstinence or continuous sobriety? Can they still be a success?
Absolutely. And we've always had the most stringent outcome criteria. But if you look at research studies, there are things like do they go back to the emergency room? And then do they overdose? Do they get chronic illnesses or STDs? Or are they the victim of trauma? Do they have legal issues? Does their child come back into their custody? These are all measures of success. They may not be the home runs that make for a great after-school special movie, but they're really important gains that change people's lives, and they're important. And we do a good job of tracking those things. In fact, we partnered with an insurance company, Health Partners, to track some data, and we published a paper on it where we track things like emergency room visits and whether they're going to meetings or not. And it worked out in our favor because we're already doing that work. So I think we've shown great integrity in this. I think this is going to happen. I think families deserve it. I think families need to know what they're getting into for healthcare. I think payers need a rubric to know what they're paying for.
Yes.
And so I think it makes sense. There are some obstacles in how it gets done, but overall I think it's here to stay, and I hope it has some traction.
And in fact, the payers, in our case, the insurance companies, they expect it, they demand it because they're paying for it. And we've seen at Hazel and Betty Ford a dramatic expansion in the utilization of insurance by our patients and our clients to access our system of care. So not only do we have a relationship, not only do we need to meet the expectations of the family or the patient, but we need to meet the expectations and the needs of the insurance companies.
That's right. That's right. And we've already evolved, but the rhetoric out in society is still, go to rehab and 28 days of that. But we're not there anymore. We haven't been there in years. All our treatment is already individualized, and And I think people deserve that, and I'm glad about the general trend in this. I'm glad that the discussion is going in this direction.
Well, a matter of fact, you just recently were participating, I believe, in a gathering of a national group of people. I believe it was on the National Principles of Quality Care. Can you talk a little bit about that? What does that mean?
Yeah, there's an organization called Shatterproof, been a tremendous advocate for all kinds of addiction efforts. And they're really focused on having standardized quality measures for different treatment clinics, whether it's methadone clinics, whether it's government-funded programs, insurance-based programs, state-run programs, and they want some quality standards. And so they convened kind of a think tank of people from lots of different sectors, and we talked about various criteria they had to try to sharpen it. It's part of a multi-pronged plan they have. I really like the plan as a whole, and I think it's going to make some positive changes for people, get people to think differently about this so that we can really show what we're doing. I'd say as an organization, people use our branding as kind of a cover to do whatever they want, and say that they kind of do it like us. But I think we're invested in this as an organization because we want to be able to show that we do great work. And so I think we're going to be willing partners in this. I think it's going to be good for us. I think it's going to be good for the American people.
At the end of the day, the experts can come together and can set these standards and so on, but when it comes down to a parent or a family that is in crisis and needs to access care for their loved one, what should the consumer, what should the family look for when they're trying to decide where to send a loved one to treatment?
There are some telltale signs, and without these standards being out there are some good questions that you can ask that really cut to the chase. If I were the parent of somebody struggling with addiction, I generally tend to gravitate towards nonprofits like us because there's a financial transparency. There's a lot of venture capital in healthcare now, and it's only going to grow. And it's not good or bad. It spawns some innovation, and so there's some good things that come from it. But if there's a conflict between mission and margin, as a family member, I want to know that the mission is going to get served first, and financial transparency serves as a custodian for that. Second thing is things like having full-time medical and mental health staff. That really shows that an organization is willing to invest the overhead so that their practitioners don't go have a side practice and don't really have skin in the game in their business. And so we have dedicated full-time mental health staff. We have some contract workers and part-time people, but we have full-time psychiatrists who don't work anywhere else other than Hazelden Betty Ford, physicians who do the same, psychologists who do the same. And I think if I'm a family member, I'm really looking for those kinds of things because this says that they have skin in the game and they're willing to make an investment. There are state laws that in California and other places, there are some hiring practices that are different, but in general, I want to know that they've invested in the overhead to help my loved one.
Dr. Joseph Lee, thank you for joining us and for being such a great advocate, not just for youth and the continuum of recovery, but also in this whole issue of quality standards and addictions treatment. Thank you for joining us today and for sharing your expertise.
Thank you.
And on behalf of Dr. Joseph Lee, I'm William Moyers from the Hazelden Betty Ford Foundation. You've been participating here in another edition of Let's Talk, a series of podcasts on the issues that matter to us and matter to you. So we hope that you will join us again for another Let's Talk podcast.